What's happening in much of the rest of the country is antibiotics are losing effectiveness, as you've mentioned. And that's due to the overuse of antibiotics and the overuse of certain types of antibiotics. So in the early 2000s, what we noticed was that the older antibiotics were just as effective in not causing those types of problems. So things like penicillin, when you prove that there's an infection that needs treatment, are very effective and don't tend to drive the bacteria to create resistance, much like some of the newer antibiotics do.
Like levaquin and what other?
Well, we label them broad-spectrum antibiotics, meaning that they kill a lot of different types of bacteria. And the strategy was, if we use those, then we don't need to really identify what we're dealing with because we're covering all the bases. Well, what that strategy has led to is damaging our own protective bacteria and leading to bacterial resistance in infections where there's no antibiotic effectiveness anymore.
I remember you telling this story when, in like 2000, in Brookings, in our conference room, that you had said to the people treating urinary tract infections, particularly, that you couldn't use levaquin or you couldn't use Cipro for a urinary tract infection unless an infectious disease person was consulted. And so they had to use the old antibiotics. And what happened at that time?
What we did, we talked with all our medical staff and all our providers, our nurse practitioners and PAs and pharmacists and so forth back in the early 2000s and just laid out the scientific case in the literature and said that if questions came up as to what antibiotic to use, just contact me and we could talk through it based on what the sensitivities were of the bacteria of our region. The huge advantage that we have in a rural area is we have one microbiology lab that tells us when we use different antibiotics what happens in our region. So we were seeing increasing resistance, much like the rest of the country, but we made the changes and started showing a decreased resistance. So our goal in 2000 was to keep our antibiotics just as effective for us in 2010, and we hit that goal. Now the goal is, can we keep our antibiotics just as effective in 2020 as they were in 2000, and we're on track to do that as well.
Right. So I remember you saying that the two big bugs that were bad are the MRSA, you know, it's commonly called, what is it called? It's called the megabug or whatever.
Superbug.
Superbug. Yeah. The methicillin-resistant Staph aureus. And Enterobacter?
Enterobacter, Pseudomonas, and then also Clostridium difficile has become the #1 infectious complication in the country.
Right, that diarrhea that comes after an antibiotic.
Exactly, after certain types of antibiotics mainly.
All right. So what happened when you made those changes in Rapid City initially?
Well, our rate of MRSA, the resistant staph, was about national average.
About like 20%, 30%?
Well, back then it would have been about 50%. And so that came down to 35%, and it was the first time in the country that had been reported you could actually lower that with the way you used antibiotics.
Right.
And so what it is now is 31%, which is about half the national average. And the reason that's important is if you have a resistant staph infection, MRSA, in the blood as opposed to a sensitive staph, the same bacteria but just a different pattern of antibiotics that you can use, you have half the mortality risk.
Half the death rate.
Half the death rate of a sensitive staph. So if you can steward the bacteria back to being more sensitive by the way you use antibiotics, then you're saving lives.
Wow. And the same thing happened, I think you said the Enterobacter went from like 30% to 0.
Yeah, we had two other bacteria that were very impressive. One was actually the Enterococcus, that had become resistant to vancomycin, and that had been 20–30%. You have a very good memory, and dropped to 0.
I've repeated the story so many times you can.
And then the Clostridium difficile across the country has created a very dangerous situation where 10% of people over 65 actually die from that infection. We don't have that strain in much of South Dakota because we've used antibiotics in a way that doesn't promote that.
So you've done really well in Rapid City, but what about the state of South Dakota? I mean, do you think it's because of your effort? I think it is.
Well, we've been accused that the magical properties of the Missouri River had some benefit, but we actually have worked with a couple of smaller communities, and we really enjoy working with the rural hospitals because they are so effective at getting things done. There's a lot less bureaucracy and so forth. And we've worked with a couple smaller hospitals on the eastern side of the state and able to replicate the Rapid City model in those hospitals, and they've dramatically decreased their antibiotic use and their amount of resistant bacteria as well.